Welcome to the deep dive. Today, we're embarking on a fascinating journey into vascular surgery. Specifically, how surgeons actually get access to the aorta.
That's the body's main artery, right? The bit, yeah.
Exactly, that critical pipeline carrying blood from the heart out to, everywhere else. And, depending on the issue, could be an aneurysm, maybe a blockage, even trauma.
Surgeons need to get to different parts of it. It's not just one uniform tube.
Right. Think of it in sections. You've got the ascending part leaving the heart.
Uh-huh.
Then it curves, that's the arch.
Okay.
Then down through the chest, the descending thoracic aorta.
Got it.
And finally into the abdomen, the abdominal aorta.
That's a great way to picture it. And to really understand what's involved, we've been digging into Rutherford's vascular surgery and endovascular therapy, the 10th edition.
Yeah.
Some really detailed chapters there.
So what's our mission for this deep dive?
Basically, to break down the main surgical ways surgeons reach these different aortic segments. We want to give you a clearer picture of the complexity and the precision involved when aortic surgery is actually needed.
Okay, let's unpack this. Starting right at the top, the ascending aorta and that crucial curve, the aortic arch. You mentioned the most common way in is a median sternotomy.
Correct. Yeah, the median sternotomy is really the go-to for accessing the heart itself, the ascending aorta, and most of the aortic arch.
How's the patient set up for that?
They're lying flat on their back, supine, arms usually tucked by their sides, keeps everything sort of stable and gives good access to the chest.
And the incision sounds pretty significant.
It is. It generally starts just below that little dip at the base of your neck, the suprasternal notch.
Okay.
And runs straight down to the xiphoid process, that little bony bit at the bottom of the breastbone.
Can it go further?
It can, yeah. The sources mention if surgeons need better access to the arteries branching off the arch, like the carotids going to the brain or the subclavians to the arms. Right. They might extend the incision up a bit towards the neck muscles or even higher in the midline.
Yeah.
But interestingly, they note that going too high midline isn't great cosmetically.
Ah, makes sense. So they might make a separate cut.
Sometimes, yeah.
Yeah.
The subclavian artery, maybe a smaller separate cut in the upper chest instead.
Okay. So once that main incision is made, it's not just zip open, right? There's a careful dissection process.
Oh, absolutely meticulous. They divide the subcutaneous tissue, the fat layer under the skin, and the pectoral fascia, that connective tissue sheet. Then they score the periosteum, the membrane over the sternum, the breastbone dividal ligament up top, and release tissues around that xiphoid process at the bottom. Sometimes they even remove the xiphoid.
And then comes the sternum itself, dividing the bone?
Yes, with a specialized surgical saw. And here's a key point from the text. They pause ventilation, stop the breathing machine during the sawing.
Why is that?
To prevent any lung injury. Safety first. Once it's split, they use electrocautery, that heat sealing for bleeding along the edges. Then they gently separate the pericardium, the heart sac, from the back of the sternum.
And then they need to hold it open.
Exactly. They put in a sternal retractor and open it slowly, progressively. Got to be careful not to spread too wide too fast.
Could damage the ribs.
Right. Risk fracturing ribs or dislocating where they join the spine. They also tie off small vessels from the internal thoracic arteries. This helps free up a major vein up there, the brachiocephalic vein.
And finally, into the heart sac.
Yep. Open the pericardium. That gives direct access to the ascending aorta and the start of those arch vessels. Sometimes they might even tie off the left innominate vein for a better view.
This is where it gets really intricate, isn't it? Identifying and freeing up that aorta, the arch, those big branches like the innominate and left common carotid.
Super intricate. And surgeons have to be really careful around the innominate artery. There are important nerves nearby.
Nerves. Which ones?
The right vagus nerve and the right recurrent laryngeal nerve, critical for voice control. The text points out they actually form a sort of sling around where the subclavian artery comes off.
Wow. So easy to damage if you're not careful.
Very easy. And they also mention that to see the innominate artery branching clearly, they might need to gently pull down on that left innominate vein we mentioned.
Okay, so that's the standard full median sternotomy. But the sources also talk about a less invasive option, the mini-sternotomy.
Yes, the mini-sternotomy. It's actually been around a while. Described back in 1949, apparently. It's become popular for certain things. Valve replacements, aortic root repairs.
The root being where the aorta connects to the heart.
Exactly. And even some ascending aortic aneurysm repairs.
So what's the big appeal of going smaller?
Well, the benefits can be pretty significant. Less overall trauma, so potentially less risk of the sternum being unstable after surgery.
Makes sense.
Patients often have less pain, less blood loss. And interestingly, fewer adhesions, that scar tissue forming around the right ventricle of the heart, because you're just not dissecting as much in that area.
So studies back this up.
Yeah, the text mentions studies, like from Svensson and others, showing it can be safe for ascending aorta and even some arch repairs, even in patients who've had a full sternotomy before redo cases.
Sounds great, but are there times it's not the best choice?
There are limits. Might not be ideal for everyone. Say someone with a chest wall issue, like pectus excavatum, that sunken chest appearance,
Right.
or patients who are significantly overweight. It just might not give enough access.
So how is it actually done? Is the patient positioned differently?
No, patient position is the same supine, arms tucked. The real difference is the incision. Smaller, obviously, in different shapes.
Like what?
Commonly an upper reverse T shape, or maybe an upper J or L. They're placed to give access to the arch and the start of those drench vessels.
And crucially,
They can always convert it. If the surgeon gets in there and realizes they need more room, they can extend that mini into a full median sternotomy, right then and there.
and the dissection, also less involved.
Well, the sternum is still divided, but only partially. A shorter midline cut, then a horizontal cut. They try to avoid the internal mammary arteries running inside the chest.
But might tie them off if needed.
Exactly, if they need more space. Then a smaller retractor holds the upper sternum apart, and the rest of the dissection down to the aorta is similar in principle, just through a smaller window, basically.
Okay, let's shift focus a bit. Moving further down the aorta, the distal arch, so the part further from the heart, and the very beginning of the descending thoracic aorta. The sources mention something called a transsternal bilateral thoracotomy, often called the clamshell.
Ah, yes, the clamshell. It's definitely a more extensive opening, usually reserved for situations needing really broad access.
Like what kind of situations?
Severe trauma, sometimes lung transplants, operations involving both sides of the chest at once, or complex problems involving both the arch and the upper descending aorta. Also used sometimes for redo aortic surgeries.
The big advantage being.
Excellent visualization and access. You can see pretty much everything in the upper chest.
But clamshell definitely sounds invasive. What are the downsides for the patient?
The main ones are needing longer ventilator support after surgery compared to a standard median sternotomy, and usually more post-operative pain because the incision is just so much bigger.
How is the patient positioned for this, and where's that big cut made?
They're supine on their back, but the right arm is alongside the body, and the left shoulder and hip are slightly raised, usually with some bumps or padding underneath.
Okay.
The incision itself runs roughly from the middle of the right collarbone mid-clavicular line all the way across to the front edge of the left armpit, the anterior axillary line, usually at the level of the fourth intercostal space, so between the fourth and fifth ribs.
Wow, that really does open things up across the whole front of the chest.
It really does. The dissection cuts through the intercostal muscles in that space. Both internal mammary arteries are tied off and divided. Then the sternum itself is cut straight across horizontally with a saw.
And then spread open.
Yep, rib spreaders are used to open the whole thoracic cavity. The pericardium and the pleural linings are freed from the back of the sternum, and the left lung is gently retracted out of the way to see the aorta clearly.
Now, the sources also mention another approach for a similar area, the left posterolateral thoracotomy. How's that different from the clamshell?
Right, the left posterolateral thoracotomy. It's another way to get to the distal arch of the upper descending aorta, but a key difference is it usually requires single lung ventilation.
Meaning the patient needs to be okay breathing with just one lung during the surgery.
Exactly. The left lung is collapsed to create space.
And the positioning is totally different for this one, right?
Completely different. The patient's lying on their right side, that's the right lateral decubitus position. Left arm is raised overhead, supported. The operating table might be flexed or broken to open up the space between the ribs on the left.
Okay.
Right arm's extended, padding between the legs, and axillary roll under the right shoulder to protect nerves. Sometimes they even hyperextend the bed a bit, all about maximizing that space on the left side.
And the incision for this side approach?
Usually a curved cut, starting midway between the shoulder blade and the spine, and following the line of the fourth intercostal space. It can be extended towards the back if needed for the arch vessels.
Could you ever need to cut the sternum with this approach?
In some rare cases, yes. If the surgery also involves the aortic root way up high, they might need to transect the sternum, which would mean sacrificing the internal mammary artery on that side.
What about the dissection itself, coming in from the side and back like that?
After the skin cut, they carefully divide layers of back and chest wall muscles, latissimus dorsi, serratus anterior, and retract them. This exposes the fourth intercostal space.
Then into the chest cavity.
Right, they enter the pleural space, the area around the lung, by cutting just above the rib. That's crucial to avoid the nerve and vessels running along the bottom edge of each rib.
Okay.
Then a retractor, often a phenocchieto, gently spreads the ribs. Sometimes, if they need lower access, they might even remove part of the fifth rib. The left lung is deflated and moved aside.
And nerve protection is key here, too.
Absolutely critical. The surgeon has to carefully find and protect the vagus nerve, the recurrent laryngeal nerve again, for voice, and the phrenic nerve, which controls the diaphragm for breathing, especially near where the left subclavian artery comes off the aorta.
Okay.
Once those are safe, the aorta is freed up from surrounding tissues and the little intercostal arteries branching off are tied. And this incision can be extended downwards into the retroperitoneum behind the belly for those big thoracoabdominal aneurysms.
All right, so now we're getting into that really complex zone, the lower chest and upper abdomen, descending thoracic and paravisceral aorta. This sounds like it bridges two major body cavities.
It absolutely does. It's a challenging area surgically. Our sources really emphasize that the exact incision and dissection depend heavily on which level of the aorta needs work.
Because you're crossing boundaries, anatomically speaking.
Precisely. It's hard to stay just in the chest or just in the abdomen. The goal is always the least extensive incision that still gives good access. And remember, the abdominal aorta can be reached on its own either retroperitoneally,
behind the abdominal lining,
or transperitoneally, opening the abdomen.
Okay, but for this combined approach, descending thoracic and paravisceral, what's the typical patient setup?
Usually a modified right lateral decubitus. So on the right side but angled, shoulders may be rotated back 60 degrees, hips rotated up maybe 45 degrees, slightly flexed legs.
Why that specific angle?
It gives the team access to the left chest, the upper abdomen, sometimes even the groin if needed. Left arms up in a sling, chest roll under the right side, maybe the bed hyperextended, and often a vacuum beanbag to keep the patient securely in that position.
Sounds like quite the production just getting positioned. And the incision must be pretty long.
It needs to be. The prep and drape have to allow access to both areas. The incision is often a gentle curve up top, helps with healing, starting near the shoulder blade tip, and following maybe the 5th, 6th, or 7th rib space, depending on how high they need to go.
Could it involve more than one rib space?
For very high exposures, yes. They might use what's called a double thoracotomy, basically entering a higher rib space through the same skin incision to get further up the aorta.
Okay, let's break down the dissection. First, the thoracic part of this combined approach.
Right. So they divide the big muscles, latissimus, serratus, maybe part of the rectus abdominis. Then switch breathing to just the right lung so the left lung collapses out of the way. Enter the left pleural space. They often cut the lower edge of the rib cage, connecting the chest part of the incision to the planned abdominal part. Sometimes a rib is partly or fully removed.
Then inside the chest?
Divide the inferior pulmonary ligament at the bottom of the lung. Place a retractor to hold the chest open. Gently retract the left lung up and sideways carefully, minimizing handling.
And expose the aorta.
Expose the lower thoracic aorta. Separate it from mediastinal tissues. Identify the left subclavian artery origin up high, being super careful of those nerves again, vagus, recurrent, laryngeal. Free the aorta all the way around from the esophagus, which sits nearby.
Then the diaphragm, the muscle between chest and abdomen.
Got to divide the diaphragm. Usually a radial cut, like slicing a pie, carefully avoiding the phrenic nerve that controls it. Some surgeons might only partially cut it to try and lessen breathing issues later. How much they cut can depend on things like how twisted the aorta is.
And then they transition to the abdominal part, usually retroperitoneal in this combined scenario.
Generally, yes. They dissect down through the abdominal wall layers on the side near the rectus muscle. Cut the rectus sheath lengthwise. Maybe move the muscle aside carefully. Cut the oblique muscles down to the peritoneum, that thin lining.
Got to be careful not to tear that peritoneum.
Very careful. It can be thin, sometimes stuck to the layer above it, the transversalis fascia, which they also cut lengthwise. Once the peritoneum is seen, they gently peel it away from the inside of the abdominal wall. Manual dissection, gentle pulling.
So creating that space behind the abdominal lining.
Exactly. The peritoneum and all the organs inside it get swept over to the patient's right side. This exposes the retroperitoneal fat.
Okay.
Then they develop a plane, a working space, between that fat and the psoas muscle running down the back. Trace that space up towards the diaphragm. Usually the left kidney and its covering, Jordas fascia, gets swept forward and medially with the rest of the contents.
And that reveals the aorta down there.
It does. reveals the infrarenal aorta below the kidneys and the visceral segment where the organ arteries branch off. The parietal peritoneum lining the wall is freed from the fat around the aorta and rolled inwards to expose the front of the aorta and those visceral artery origins.
Can you see the right kidney artery at this point?
Usually not, unless the aorta below the kidneys is divided or really moved around significantly. But you do need to find the left ureter, the tube, from the kidney on the back of that peritoneal sac, especially where it crosses the iliac artery lower down.
What about identifying those crucial visceral arteries? Renal, mesenteric, celiac.
The left renal artery is a key landmark here. There's often a vein nearby, the renal-lumbar vein, that needs tying off to let the kidney move more medially for better aortic access.
What if the renal vein runs behind the aorta? That sounds tricky.
That's rare, a retroaortic left renal vein. It makes moving the kidney tough. If that happens, they might leave the kidney put and tie off the vein further out, relying on other veins to drain the kidney. Trying to detach and reattach it in that situation is usually avoided too much tension, too risky.
And to get really good exposure right at the origins of those arteries.
They often need to divide the diaphragmatic crust, that muscle part wrapping around the aorta as it comes through the diaphragm, and maybe the median arcuate ligament too, another fibrous band. That helps mobilize the visceral aorta so you can clearly see and work on the origins of the left renal, the superior mesenteric, and the celiac arteries.
Okay, let's focus purely on the abdominal aorta now as a standalone procedure. You mentioned both retroperitoneal and transperitoneal approaches. Let's start with just the retroperitoneal approach for the abdomen.
Right. So the retroperitoneal approach just for the abdominal aorta is used to expose the lower descending aorta and the abdominal aorta itself, including the bit near the visceral arteries, the paravisceral segment. Key thing, no opening the main abdominal cavity of the peritoneum.
Why choose this? What are the advantages?
Well, studies suggest it might lead to shorter ICU stays afterwards and maybe quicker return of bowel function compared to opening the abdomen fully, the transperitoneal way. It's often good for that paravisceral area and for type IV thoracoabdominal aneurysms.
And patient positioning for this?
Similar to the combined approach, that modified right lateral decubitus, but maybe less hip rotation, like 20, 30 degrees. Right leg usually bent a bit.
Where's the incision made for this purely abdominal retroperitoneal access?
Usually starts midline, down low between the belly button and the pubic bone, then curves out sideways towards the 10th or 11th rib space. It can be extended higher up along the rib space if needed for more proximal access.
But that risks.
Risk accidentally getting into the pleural space, the chest cavity. Surgeons try hard not to cut the rectus muscle fibers to prevent hernias later. If they need the right iliac artery, they might cut the back layer of the rectus sheath but leave the muscle intact. Then the oblique muscles are cut head to tail down to the peritoneum.
And the dissection inside, creating that space.
Yep, creating the retroperitoneal space. You can either continue in the preperitoneal space like we discussed before, or carefully sweep the peritoneal contents off the psoas muscle. Again, stay in front of the psoas to avoid nerve injury. Genitofemoral, ilioinguinal nerves are there.
Okay.
Then a retractor holds the abdominal wall and the swept-over organs to the patient's right.
The text mentioned an alternative dissection plane here, too.
Yes. You can also develop the plane between the preperitoneal fat and the deeper properitoneal fat. This lets you sweep the preperitoneal fat and the peritoneal contents medially, but leaves the deeper stuff, including the kidney and its fascia, more in place.
What's the trade-off?
It might limit how high up you can get on the aorta, but it involves less kidney manipulation. Either way, you eventually reach the aorta and dissect the fat around it. If the deeper fat stays, you need to spot the gonadal vein and ureter to make sure they aren't pulled medially by mistake. If the kidney stays put, sometimes tying off the gonadal vein where it meets the renal vein helps retraction.
And dissecting the aorta itself.
Similar to the thoracoabdominal approach once you're there. Dissecting the infrarenal and paravisceral segments. Careful to avoid the lymphatics behind and beside the infrarenal aorta. Best plane is usually front and side, below the kidneys. Identify, tie, and divide the inferior mesenteric artery that helps retract the peritoneum further for better exposure.
Okay, now let's switch gears to the transperitoneal approach for the abdominal aorta. When is opening the belly preferred?
Generally, when you need really direct access to the visceral and infrarenal aorta, both renal arteries, the hepatic artery, or the far ends of the celiac and SMA, you can get to the origins of the SMA and celiac retroperitoneally with a lot of spleen-pancreas mobilization.
But transperitoneal is more direct.
More direct visualization, yes. but it involves significant handling of the abdominal organs, the viscera, so it's used more selectively when that direct access is really necessary.
Patient position for this one.
Simpler, just flat on the back, supine, arms out to the sides.
And the incision is usually that standard up and down cut.
Yeah, usually a midline laparotomy, guides way down to pubis, or sometimes a transverse smile incision across the upper abdomen. That transverse cut goes through muscle, risks nerve issues, but some find it's better tolerated if the patient has bad lungs.
Once inside the abdomen, what's the process?
Well, first maybe a quick look around. Then, for the visceral aorta exposure, they often do that left medial visceral rotation maneuver.
Remind.
Cut the attachment of the left colon to the sidewall, then rotate the left colon, spleen, stomach, pancreas, all towards the midline. Hold everything open with a retractor. Wrap the organs in moist towels. Sweep them gently to the right.
Need to free up the spleen?
Yes. Release its attachments. Mobilize it up and medially. Dissect behind the spleen in front of the kidney, dividing ligaments, splenophrenic, splenoconic, splenorenal. Develop a plane behind the pancreas. Separate spleen and pancreas from the back wall, and rotate medially until the suprarenal aorta above the kidneys is exposed. Left kidney might stay put or be mobilized too.
And getting higher up.
Dissect the fat around the aorta, maybe divide the left crust of the diaphragm, potentially divide the median arcuate ligament to find the celiac artery origin. Similar principles to the other approaches once you're exposing the aorta itself.
What if you only need the infrarenal aorta below the kidneys via this transperitoneal route? Is all that organ rotation needed?
No, generally not needed just for the infrarenal aorta. You lift the small intestine up and to the right, cut the base of its mesentery carefully in an avascular area, divide the ligament of Treitz that supports the duodenal jejunal junction, then mobilize the duodenum, the first part of the small intestine, fully to the right, being careful near its blood supply. Sometimes you might tie off the inferior mesenteric vein for better exposure around the renal vessels.
Then find the left renal vein.
Exactly. Identify the left renal vein. You might need to tie off the gonadal and lumbar veins draining into it to allow the renal vein to be gently retracted up or down. Ligating the adrenal vein helps retract it down. Then you can circle the aorta just below the renal arteries. Watch out for that tricky retroaortic left renal vein again.
And further down.
Proceed downwards, identify the inferior mesenteric artery, decide whether to preserve it or ligate and divide it based on the plan.
And finally, controlling the blood flow down low, clamping the aorta or iliacs.
Yep, distal control. You can clamp the aorta just above the bifurcation where it splits, or clamp the common iliac arteries individually. When circling the distal aorta, watch out for the middle sacral artery in the back.
And the veins nearby.
Crucial. The left common iliac vein often crosses over to the vena cava right near the bifurcation. You have to clearly see and separate the vein from the artery before clamping the artery to avoid injuring the vein. Big trouble if you tear that.
Is one side easier than the other?
The right common iliac bifurcation is usually easier to see and control. The left can be trickier, might need to lift the sigmoid colon's mesentery, but you want to avoid too much dissection around the iliacs to protect the sympathetic nerves there.
What about aneurysms in the iliacs themselves?
Sometimes, if there's a common iliac aneurysm, the graft used for the aorta repair can just be passed through the aneurysm down to the bifurcation without needing to slice the iliac artery open lengthwise.
Wow. So just to wrap this up, it's incredibly clear from this deep dive that getting surgical access to the aorta is, well, profoundly complex. So many different techniques.
Absolutely. And each one, sternotomy, thoracotomy, retroperitoneal, transperitoneal, is highly specialized, chosen very carefully based on which part of the aorta needs fixing and the patient's specific situation.
Each route has its own pros, cons, technical hurdles the team has to manage.
Exactly. It really underscores the precision involved.
It really does. And it makes you think, too, about where things are heading. With all the advances in minimally invasive techniques we hear about, what questions does this raise for you about the future? How might these approaches continue to evolve?
That's the big question, isn't it? How will minimally invasive methods change the game further? Could they eventually offer similar access with even less impact on the patient, improving outcomes and recovery even more for these major operations?
Yeah.
It's definitely an area of constant innovation.